Well, I can take the moderator's privilege here and introduce myself. This was a good talk for me because this is, I'm sure, one of those things where it's seen me and I haven't seen it. We've read a lot about problems with Latarjets. I was privileged to review, Shaw was the lead author, but JP was the senior author on the complications with Latarjets at 25%. In fairness to JP, this was a really difficult population. Almost all of them were multiple failed revisions, but it certainly gave all of us pause as to the risks with Latarjets. Adwal and Frank, similar complications with Latarjets. But generally what we hear about with Latarjets are the things we've heard all day, which are neurologic injuries, which are obviously terrible, recurrent instability, which is much higher for most of us than Walch infections, and then hardware issues. So one of the ones I was not aware of as much was Giacomo's work with graft resorption. And he was the first person about 10 years ago to look at graft resorption via post-op CT. And I can't say I'd seen this, but again, I think as we go on to present this, you'll see why. Most of these patients are doing well, and after the initial x-rays that I get in the office, I don't normally re-x-ray or re-image otherwise asymptomatic patients. So he looked at osteolysis in some detail. He was able to get CTs on a bunch of patients at 17.5 months. All of these patients showed some osteolysis. Generally, it's in the anterior and superior part of the graft. Patients with more bone loss had less osteolysis, as you can see. And interestingly, the amount of osteolysis had no effect on the outcome or their Rowe Walch Duplaix scores or their simple shoulder test. So Benny, as another author, looked at this after Giacomo and looked at strength as well. One of this showed 80% of the grafts in this study out of India showed osteolysis, again, usually the superior portion of the graft. So I'm going to probably say it wrong. Haney from Journal of Shoulder and Elbow Surgery was the one that kind of woke me up to this a little bit, since these patients aren't unstable usually, but they'll get anterior pain as this graft resorbs and the screws get prominent. So Haney was the first one to report this. They could not define a specific amount of graft osteolysis that would cause this, but their point was they needed to raise awareness of shoulder surgeons regarding coracoid bone graft resorption that recurs about 6 months. And if you're getting patients with anterior shoulder pain, think about painful hardware. Gupta and LaFosse were the first people in a review that I'm aware of that described graft osteolysis specifically as a complication. And they also pointed out that anterior shoulder pain can necessitate hardware removal. They used the horizontal adduction test, which we've traditionally used for AC pain, to make a diagnosis of this painful anterior hardware. Zhu looked at about 63 patients with CT. 90% of these had some graft osteolysis, and 10% had what they described as grade 3 graft absorption with complete exposure to the screws. You can see the CT from their article here. So that's a much higher number than I would have expected based on my own experience. Interestingly, like most everybody else, graft osteolysis didn't correlate with recurrences or any numbers that they measured, and I made this a deliberately busy slide, but elevation, external rotation, intra-rotation, ASES scores, and constant Murley scores were unchanged, even if they had profound osteolysis. Balestro did an interesting article looking at bioabsorbable screws, a good idea perhaps to avoid hardware problems, but this actually was worse. 67% of these had severe osteolysis, and these authors abandoned bioabsorbable screws for Latarjets because of this. Domos and Walch also talked about this complication, bone block resorptions, usually without increased recurrence of instability or poor outcome. And once again, non-specific and no guidelines, but if the osteolysis creates proud hardware, it may need to be removed. So this raises a larger question, is since the bone block can go away with absolutely no effect on the outcome, is it the bone block or the sling? And we've heard a lot today about it's the bone block. And to me, this data suggests maybe it's more of the sling, or it may be both. Hovelius looked at this with only plain x-rays. Obviously, plain x-rays is not very sensitive to pick up graft resorption. He was far more likely to see reoccurrences with medial graft placement, but resorption, non-union, and migration did not affect recurrence rates in his very large study. So in summary, osteolysis is extremely common, and if you look for it, it's going to be there. Severe osteolysis in about 10% of patients. It has no correlation with PROs or recurrence rates. It does raise questions about whether it's the bone block or the sling, since those patients do quite well with literally no bone in place at 6 to 12 months. Yamamoto did an excellent cadaver study that also confirmed this, so food for thought when we're doing free grafts and allografts and things like that. But be aware that osteolysis sufficient to expose the hardware may have to be removed, and if you're getting anterior shoulder pain that's made worse with a horizontal adduction test, it's probably something you want to think about. Thank you very much.